Building on the last lecture, looking at the life and work of Balfour Mount, I want to now look at the early history of palliative care in Canada. And it has been so successful, it can seem like it was a foregone conclusion, but when we look at the actual history, it was not. It took Herculean effort by these pioneers and the groups of people that they managed to build up around it. It also required coordinating with provincial governments, national governments, fundraisers, volunteers, other physicians, nurses, and social workers, etc. So it's a very complex task that Balfour Mount was heading up, and so I do want to look at it. But before I get to that, I want to talk a little bit about where we're sitting right now. So I will be attaching this to Blackboard. It's the Canadian government document on palliative care, and it's a framework that's been developed by the federal government. And this came quite late. This comes in 2017. So we can see that from the 1960s to now, it's taken all of this time to get it to the point where we're seeing the healthcare system really taking it on as it's become a kind of a part of our healthcare system, or it's almost at that point. So in the executive summary, it says, in late 2017, the Act providing for the development of a framework on palliative care in Canada was passed by Parliament with all party support. So that's interesting in and of itself, because anybody who knows Canadian politics knows that getting all party support pretty difficult. And so this also speaks to the fact, and this is something that we see also at the provincial level, that regardless of political affiliation, people recognize the necessity of hospice and palliative care. It seems to cut across whether the person's secular, whether they're religious, although a lot of the people pushing this have been religious, as I'm going to talk about when we look at the case in Ontario with the Compassionate Care Act. But so they get all party support, and it comes into effect in 2018. So as we know with Canada, it's a very complex system, with the provinces really being the ones overseeing healthcare, and the government, the Canadian government, sort of over it as an umbrella. And so creating this framework took a huge amount of coordination with provinces and territorial governments, etc. And so according to the executive summary, this framework is based on the World Health Organization. And this is another tendency in Canada to link itself internationally and look to the World Health Organization as kind of the model. A lot of our healthcare does that. A lot of healthcare around the world does that, sort of seen as best practice. So looking to the World Healthcare Organization of definition in the Canadian context. So this becomes the issue, and this will become the issue for palliative care and hospice around the world. How do you adapt it within different situations? We saw with Cicely Saunders and Florence Wald, those are very specific situations they're dealing with. So for instance, in the case of the US, a private medical system, so very different. So in the Canadian case, same thing. The situation is different. So, so this executive summary notes that this is a dynamic situation, that it's changing all the time. And so the 4 priority areas are palliative care education and training for healthcare providers and caregivers. So that's where we fit in there. And certainly this is something I'm very concerned about, is ensuring that people that are training in medical fields are getting this information. Measures to support palliative care providers, research and collection of data on palliative care. And again, as I've been saying throughout the course, there's really very little, just as an example, when you look at the history of palliative care in Canada, there's very little actually written. Measures to facilitate equitable access to palliative care across Canada, with a closer look at underserviced populations. So this issue of, although most Canadians live in cities, there's significant, I think it's around 16% of people live rurally. There are Indigenous communities all over Canada. So making sure that everybody has access to those services are, of course, a challenge. And so the larger background that's driving this to some extent in the Canadian case, as it says in Part 1 background, death and dying in Canada. So it says over 270,000 Canadians die each year. 90% die of chronic illnesses such as cancer, heart disease, organ failure, dementia, or frailty. So this is pointing to the fact that, as we talked about earlier in the course, people tend to live to old age. I mean, this is wonderful thing, but it creates a different scenario with death and dying. So the government is recognizing the role that palliative and hospice care can play in the fact that this is people tend to be living into old age. So by 2026, the numbers of deaths are projected to increase. So that's obviously, we have the baby boomer generation. And it goes on to say, despite Canadians' wishes to die at home, 60% die in hospitals. So this again is the driver, and there's many reasons why. So all of you will likely know that taking care of these issues, unless there's a palliative care unit in the hospital, is a very expensive way of dealing with this. It's not an optimal environment. And so increasingly the provincial and federal governments are recognizing that hospice and palliative care, whether it's in home, in hospital, or in a freestanding institution, can step in and help. And I'm not going to candy coat this. It's cost effective. That's been a huge driver of this. And so it goes on to say the term palliative care emerged in Canada in the mid-1970s, initially as a medical specialty serving primarily cancer patients in hospitals. So we know that already about the early history of hospice, that it was primarily directed at cancer patients at that time. But as it goes on to say, with an aging population now, it's been expanded to everyone. So the idea of pain and symptom management, psychological, social, emotional, spiritual, and practical support. So even within the government document, I went looking for this because this often gets downplayed, but they're including the spiritual aspect along with these other factors: psychological, social, emotional, spiritual, and practical support for caregivers during the illness and after the death of the person they are caring for. So you can see this is a very different approach to traditional biomedicine as it emerged in the mid-20th century. So it's a kind of wraparound care. So it's caring for the person, it's caring for their family, it's helping the people supporting them, but it's also dealing with grief and bereavement. So we will talk about that later in the course, but the idea that hospice and palliative care also try to contribute to working with grief and bereavement. So this is really recognizing the whole humanity of the person and their family. In looking at the timeline of the creation of palliative care in Canada, we can see that the first palliative care unit within a hospital setting occurred in Winnipeg St. Boniface General Hospital, and this hospital came out of the Catholic tradition, and so palliative care was something that they were very familiar with. And so there's not that I can find much written on this history, but when you go on their website, this still exists, and it's become part of Manitoba's healthcare system. So I really hope somebody does some work on this at some point. But that was the very first one, and very shortly after, we see Balfour Mount opening a palliative care unit at the Royal Victoria Hospital in Montreal. So I just want to look at that. And so Mount in his book recognizes that the unit in Winnipeg is the first, and then he says, but no one had attempted a full clinical unit integrated into, and in this case, a teaching hospital. And so he frames this in his memoir as with the questions, can a hospice program function successfully within a general hospital? So that becomes the question. And so he develops, along with his allies, a pilot project. So it was originally going to be 1 year, and then he convinced them to go for 2 years, and the Quebec government stepped up to fund a 2-year pilot project. So we can see here that the government is not on side. I mean, they're open to the idea of it, but they're not convinced that this is going to be useful or helpful. So it's really requiring the drive of Balfour Mount to get this to happen. And without a doubt, the fact that he's a very well-respected surgeon contributes to the ability to make this happen. And so, in the memoir, he's very appreciative. He says the Quebec government stepped up to help. So he also is very active in finding funds, and so he's doing fundraisers, and so money's coming in from a variety of sources over the years. And another part that can sometimes get lost in all of this is he was very savvy about using the media. And so he invited the CBC to come and film. He wasn't very happy with the documentary that they did, although he got a lot of good response from that documentary. He felt that it was called And Death Shall Have No Dominion. He felt it made it look too frightening. but there was a very influential article that came out in the Montreal Gazette that resulted in a lot of response and created this kind of positive buzz around this pilot project. So we can see that he's being very, very savvy about how he's building out his pilot project to make sure that it gets adopted permanently. And so in the section in his memoir he calls Growing Pains and Building the Team, he writes on page 276, it soon became clear that the RVH PCS team, so the Royal Victoria Hospital palliative care team, had to include the larger public, the provincial government, the RVH community at large, and then with these foundational elements in place, a skilled, carefully selected, collegial, interdisciplinary group of professionals and volunteers. Team building had to be intentional and inclusive of the broader community, with wide layers of support for the critical nucleus of day-to-day caregivers. So he's aware of how complex this is, that he's having to gain support from within his own hospital, so the CEO of his hospital, the government, the larger Quebec community. So this is a very complex task that he has set for himself. And so he says the idea was, could St. Christopher's level of excellence be developed within the existing institutions of Canadian healthcare? So that's what was the basis of the pilot project. And so he's seeing if this model will work in a Canadian setting. And so he's also very carefully looking for other physicians and nurses and social workers who share his vision. And so these first pioneers often were leaving successful practices and taking a risk in this new approach. And it takes that kind of personal courage to get these things off the ground. And so we see he has a number of supporters as he's moving along, and many, or almost all of whom, he sends to St. Christopher's. And so this kind of becomes the rite of passage, that each person goes to St. Christopher's and they see how it's working. And so after the 2 years of the pilot project and all of this very complicated development of this unit for the first time, he writes, the verdict comes in. And so he includes a letter here. Dear Balfour, on my recommendation to the Board of Directors at their meeting of October 22nd, 1976, the palliative care service was confirmed as a continuing patient care service in this hospital. This takes it out of the category of a pilot project and assures its future activities. With reference to the various recommendations included in your report, steps were initiated to study these recommendations and their financial implications, at the conclusion of which decisions will be taken concerning the proposed expansion of the service. Okay, so clearly, and as we know, he was successful in what he was doing, and so it becomes a permanent part of the hospital. And then as a result, much as St. Christopher's was in terms of separate institutions, it becomes a model for this throughout North America and probably internationally. As I mentioned at the very beginning of the course, and it's called hospice and palliative care, there is a subtle difference in those two things, and there's a reason for this. And the reason that Balfour Mount ends up creating a separate term from hospice is related to the Canadian situation, and it really speaks to the way that these services have had to sit within their own environment if they're going to be successful. And so he recounts in his autobiography on page 233 his struggles with this. And so he writes, a hospice at Royal Victoria Hospital, mais non, mon ami, ce n'est pas possible au Québec. Okay, so he's speaking to a Quebecois colleague. He says, my friend went on to explain that while in England the term hospice may evoke images of hospitality and a resting place for travelers, among Quebec francophones the term brought to mind neglect and the warehouse-style nursing home shabbiness of les hospices in France. Okay, so this is very specific to the French and French-Canadian setting. So this is in the mind of people when they hear that. It has a very negative connotation. So clearly that's going to be problematic in the situation he's facing in trying to gain support in Quebec. So he says, how disappointing. I had liked the idea of Vic having a hospice. So his original plan had been to call it a hospice within the hospital. The term, I believed, would have the advantage of ambiguity in a culture in which end-of-life care had meant hopelessness rather than excellence of care and quality of life. In 1973, few in North America had ever heard the word hospice, and I would say that's still largely true. Hospice Inc., later called Hospice New Haven, would be known as the first American hospice, was still only a glint in the eye of Florence Wall, Dean of Nursing at Yale University. The term hospice would not bring connotations of death and despair to mind in English-speaking Canada, or any connotations at all for that matter. I thought the name would be perfect. Apparently not. The implications of the word for our Francophone colleagues would be disastrous, so they would reject it out of hand just because of the connotations. Now, just to note, as you all know, we in English-speaking Canada, the term hospice is used and there's no problem. So what would we call it? So he's going through the possibilities of what he's going to call it. Critical care service, end-of-life care, hardly. I was drawing a blank. So he says, this is one of these famous origin stories. As I showered the next morning, my name chasing continued. What exactly is the goal of our proposed program? Clearly, it is to improve quality of life, to mitigate, to improve the quality of. What about palliative care? But what is the etymology of the word palliate? So he knows the word from his own medical training. So he says the term as used in 1973 had come to imply non-curative, as in palliative radiation therapy, but the etymology of the word was interesting. Palliate, it turned out, was derived from the Latin word pallium, meaning a cloak. The pallium was a short outer garment of Greek origin, but common among Romans and Jews as well. It was worn by both men and women and was rectangular in shape. Held by a brooch over one shoulder, the pallium descended to just above the knees, and thus it hid or concealed those areas that might be covered by an undergarment. So this idea of a cloak. So he says, problem solved. To palliate is to mitigate, thus to improve the quality of life. And so also I would say in the kind of the feeling of the term, how many people understand it is that idea of cloaking, of caring, of nurturing, of taking care of, protecting. So that's also in the etymology. And so he decides our program would be the Royal Victoria Hospital Palliative Care Service. And so he goes on to say that he wrote to Cicely Saunders and Robert Twycross, who was the person that was very involved in developing ideas of pain management and palliative care. And Cicely Saunders did not like it. So she rejected the idea, and he said, I went ahead anyway. So we can see he's a disciple, but he has his own thoughts on these matters, and he also recognizes that he's in a different context. And he says with some satisfaction that the British system eventually did adopt the word palliative care as well as hospice care. So to end this lecture, after the very successful pilot project in Montreal, what we see is an efflorescence in the Canadian setting and in the United States and in Britain. And so what this tells us is that there was a need and a gap, which all the three pioneers obviously and their teams recognized. And so very quickly it gets taken up, and I'll be talking about this separately, but we see the development of subdisciplines of palliative care within medicine, within nursing, and that becomes part of the curriculum for many of them, and I'll be looking at that. We also see the creation of journals dedicated to this, some of which you have already used in your own work, and we also see the creation of a variety of foundations at the national and provincial levels. And so this becomes a very complex landscape. I'm just going to touch on one of the most important was the creation of the Canadian Hospice Palliative Care Association, which was founded in the 1980s. And so I'm happy to say that their current president is Vivian Papes, who was the chair of the board at Nipissing Serenity Hospice, and I will be talking about her more towards the end of the course when I talk about Nipissing Serenity Hospice. But she is currently she's a palliative care nurse, and now she's the president of the Canadian Hospice Palliative Care Association. And so we can see here that they move through the timeline, that it was formally established in the early 90s, and they hold general meetings that then invite people from the provinces. And so, as I was saying earlier, this is a complex landscape. It is in any country, but in Canada, where you have the provincial government and the provincial governments kind of having to coordinate. And so this becomes a kind of a clearinghouse for palliative care, and I will be attaching the link. And so, just to give you an example, on the website, it has awareness, initiatives, advocacy, education, conference, and events. And then it has a whole section on explaining what palliative care is, who funds it, the benefits, and then it has all the different provinces. So this is obviously, if somebody hears about it, they don't know what to do next, it becomes a go-to that you can go onto this website. So this is the kind of the overarching Canadian website. So as I said, I will be linking this on Blackboard.